All right. Give us 1 second. We've got a little information to pass out here. In just a moment, I'll get a couple of other people on board to get this ball rolling. And then we'll see if we can give you the information that you're looking for. So give me 1 second. And Ashton, if you are there.
There I am. All right, thank you guys for attending. You're going to get some great information today about rotator cuff and shoulder pain. I just wanted to do a couple of housekeeping things. If you have questions during the presentation, down at the bottom of the screen, you have a chat option and a Q&A section. Feel free to put any questions you have in either of those sections. And if it's a question that Dr. Haynes is going to answer live, I'll probably let you know that. Otherwise, there will be a section where I will ask all of the questions to him so he can get you your answers. And you should have all gotten an email with a worksheet. So if you will, you want to pull that out, because throughout the course of the presentation, he's going to answer those questions and help you fill in the blanks there. All right, and I'm going to pass it off to Dr. Haynes, who has all of the info.
All right, well, fantastic. Well, here on this screen, I've got a little arrow pointing down to the Q&A button, where if you want to ask some questions, feel free and we'll try to answer those. It's also pointing down to a link on the web to freeshoulderscreen.com. And I'll go ahead and tell you, we're going to give you some really good information, a lot of things that you'll be able to think about what's going on with your own shoulder and your shoulder pain and your rotator cuff, and make some decisions on what you think is going on with yours. At the end of the day, I can make a guess, but until I take a look at a person's shoulder, because everybody is unique and everybody is different, at the end of the day, at the end of this webinar, what I'm going to do is offer for you to come in to see me free of charge. There's no obligation. And if you want to do that, I'm going to go ahead and encourage you, hit the Q&A button, talk to Ashton, talk to Casey, and talk to them about that. Or if you want, you could also just go straight to freeshoulderscreen.com and sign up for that sort of thing there. Again, there's no obligation. I just want to be able to give a person an idea of what I think is going on with their shoulder and what they could do to help get rid of the shoulder pain and get normal motion back. So let me just kind of get rolling here. So very first thing, I'm going to ask if anybody's had any shoulder pain in the last 30 days. And I'm going to sit here and I'm going to raise my hand. I'm also a member of the Shoulder Pain and Rotator Cuff Club. I've dealt with shoulder issues for, I'm going to say lots of years. It's been decades that I've dealt with mine. Because of what I'm going to present here, I'm going to let you know that mine don't interfere with the daily activities that I do. I can still go play golf. I can do anything that I want to do, and I still have some damage in both shoulders, quite honestly. So that's the question. You've had some shoulder pain over this past 30 days. We're going to talk about your pain in just a little bit. I just want you to be aware of, that's what we're dealing with, is some pain in there, and we want to get to some solutions for you. And so let me move on past that. So the first question is, what is the rotator cuff? And the rotator cuff is a complex joint in the body. There are several things that comprise the rotator cuff or the shoulder itself. So we're talking about the bones, the joint itself, and then the muscles. And so let's talk about, and forgive me for my delay in working my technology here. So we mentioned the bones. Let's talk about the bones and what actually makes up the architecture or the structure of the rotator cuff itself. So the bones, there are three main bones that we're going to talk about. The first one is the upper arm or the humerus. The second one is the shoulder blade, it sits on the back side, we also call the scapula. And then the third bone is the collarbone or the clavicle. Now there's a third piece that comes off of the shoulder blade right over here, if you can see my little arrow, and that's called the acromion. And the acromion gets very important whenever we're dealing with rotator cuff and shoulder issues, because a lot of times that is kind of the point where we see the issues take place. So whenever we treat shoulder issues, that one's a big one. So the acromion, and you don't have to remember the words, just that's that fourth location on those three bones. So let's talk about the joint. The body has lots of different types of joints. For example, the knee joint, the finger is definitely a different type of a joint than we have in the shoulder, in the rotator cuff area. The shoulder is actually very similar to what we have in the hip. So at the end of the upper arm, there's a ball. That means it's a half ball that sits inside, and we'll look at this next piece, inside a socket. And so it just creates a nice little ball and socket type of a joint that gives us the reason we're built this way is because the shoulder has more movement, more motion than any other joint in the body. It's got more mobility. It lifts up and down. It lifts side to side. It rotates. It comes across. It comes back. So it's got more degrees of movement than any other joint in the body, and it's this ball and socket joint that lets that happen. Now, one of the problems with the shoulder in this ball and socket is the socket is so small relative to the ball that it creates a lot of instability there. And so I like to describe it as the ball in the upper arm is similar to a golf ball sitting on the socket, or you think of sitting on the tee. So you've got this big structure here sitting on this little surface over here. And so it creates, for function, it creates a lot of movement here. The problem is if there is some injury, if there's some muscle imbalance, if something's going on, then all of a sudden it's not quite as stable as, say, the knee joint or some of the other joints. So it's a pro and con situation with that. As long as it's working well, we're not having any issues, it's fantastic. Once we have some issue either with one of the muscles of the rotator cuff or some of the bursa or one of the structures, then it becomes a little bit more challenging. And then that's where we have to intervene and see if we can make a change in the mechanics of how the thing is working. So let's also take a look at the muscles. And you definitely don't have to remember what these are. So there are four muscles that make up the rotator cuff. We call them the sits muscles. The very first one, and I'm going to be honest, this first one is the one that we tend to see more injury, more problems with than any of the others. And it's called the supraspinatus muscle. And it sits right on the top, and it goes from the upper part of the shoulder blade all the way out to it attaches onto the upper arm bone. And it travels underneath the acromion right here. So there's a lot of stuff that happens in this general area right here that we'll talk about. The second muscle is the infraspinatus, and that sits right below on the bottom part of the shoulder blade itself, and it comes over and attaches just a little bit further down on the upper arm bone right there. The third muscle is the teres minor muscle. It's pretty uncommon for this muscle to be involved with a rotator cuff problem, but by definition, it does meet the criteria of being included. So we talk about that one just a little bit. It can be injured, but it's not that common of a problem. And then the fourth muscle is actually on the front side of the shoulder blade. And this muscle, it's called the subscapularis. This muscle sits next to the rib cage on the front side. And whenever we have pain or problems with that muscle, we tend to feel it more on the front. And so that's one of the things that we look at there. So those are the four muscles that make up the rotator cuff. There's a lot more musculature that gets involved. There's some muscles that lay over, attach onto both the shoulder blade and the collarbone, and then attach onto the upper arm. The deltoid muscle, the upper trapezius muscle as well. It sits right here. And so those are the big, powerful movers of that whole structure. But as far as function and movement of the rotator cuff, or the shoulder itself, it's these four muscles of the rotator cuff that we focus on. And so what becomes key is in the different systems in and around the shoulder working together. And so there are four main areas that we like to look at. If there's a problem with the shoulder, if we leave one of them out, we may really miss some good response, some good return and function. So the first thing we look at is in the neck. Because of how close it is to the shoulder, an issue in the neck can really have an impact on what's going on in the shoulder itself. So treatment of the shoulder, we have to take a close look at how the neck is moving. Whenever a person goes in to the doctor and they, a lot of times they'll have some neck pain and some shoulder pain, which is actually very common. And one of the big challenges is to determine, is it a neck problem or is it a shoulder problem? And quite honestly, we kind of look at them together because it is hard to break the two out. We can look at imaging, and imaging may show that there's a neck issue going on and there's a shoulder imaging going on. So we just look at both of those together at the same time. The next piece is the collarbone. So the collarbone comes out and attaches onto the front side of the acromion right here, and then it comes around further to the front and it attaches onto the chest bone. And so really and truly, this is the only bony connection of the entire arm to the body is in this little area right here. So it kind of stabilizes the shoulder a little bit. From time to time, you've probably heard of somebody saying they separated their shoulder. Well, that usually happens right here. You get a hard pull, you get some tearing and some ligaments, things of that nature. So that separation takes place right there. Well, whenever that happens, the collarbone can get stuck, for lack of a better term, and a change in how that thing works will impact how that shoulder moves as well. So we have to look at the collarbone in addition. The shoulder blade becomes a really important piece. Somebody that's dealt with shoulder pain and problems for a while tends to hold it up next to them and protect that shoulder. Well, the muscles around that shoulder blade stop, they tighten and they stop letting that shoulder blade move a lot. And so what tends to happen is all of a sudden we'll see a person trying to lift like this. And so if we don't have good movement out of that shoulder blade as well, then we don't have the movement that we're looking for out of the shoulder. So that shoulder blade is another really important piece. And then finally, the rib cage itself, and specifically the first rib, maybe the second rib. Muscles that come off of the skull and off the neck come down and attach to this first and second rib. And likewise, that first and second rib can get stuck. And whenever that happens, then we have a change in how that shoulder functions. So we have to make sure that that first rib and that rib cage itself is moving and functioning like it needs to, so that the shoulder itself can continue to do its job effectively. So it takes all four pieces working together just to be able to do this function right here. And so we mentioned the worksheet. I'm going to try to follow that as closely as I can. So we've just answered some of those questions in here. So let's look at that form. Let me move on from there. There we go. So on the form, the first question, what is the rotator cuff? Well, it's a group of four muscles that move the shoulder. The shoulder is and the second one, the shoulder is a ball and socket joint. And then lastly, the four areas that work together for shoulder movement is the neck, the collarbone, the shoulder blade, and the rib cage. And if we need to go back and answer these, just send us a message and let us know. And again, you can see at the bottom of the screen, I've got the go-to freeshoulderscreen.com. Again, if you want to go ahead and jump on that area and set something up, again, I'm going to offer 10 people the ability to just come in for free. Let me evaluate that shoulder. Let's take a look at it, and I can give you my idea of what's going on. So that's, if you get a chance, jump onto that, or just message down at the bottom. So how did I come to specialize in shoulder and rotator cuff treatment? Well, quite honestly, my first experience dealing with shoulder issues was back in high school, which has been a long time ago. I have some other injuries from my high school football time, but I dislocated both shoulders. I dislocated the left one on one play, came out, they put it back in place, went back in the next play, and then I had the same thing happen to the other side. So as a 17-year-old, it wasn't that big of an issue. I was able to bounce back really fast and not have any problems. Fast forward 20 years, and all of a sudden, some of the things that were happening in my shoulder weren't quite right anymore. And I had to take a look and see what I could do with them. Fortunately, I'd learned what to do with the shoulders at that point. So it became an easy situation for me to treat that myself. And so that's my experience with it. My educational piece, I graduated from Texas Tech University in 1994. So I'm in 26 plus years of treating shoulders, as well as everything else in the body, but especially on the shoulder end of things. I graduated from MGH in Boston in 2012 with my doctorate degree in physical therapy. Some achievements, some I'm very proud of. I am the author of Neuromuscular Dry Needling. I'm a senior instructor for Dry Needling Professional Training Series, and I do some guest collegiate lecturing as well as teaching other clinicians on that process. And we'll talk a little bit more about dry needling a little bit later about what that is and what that can do. And then finally, my clinical experience. I haven't updated this in a little while, but I've treated or supervised over 500,000 patient treatments in my time as a physical therapist. Related to dry needling, I've had over 30,000 patients using, it's probably closer to 250,000 needles at this point. And so I don't want to frighten anybody about the idea of dry needling. It is an innovative treatment approach that we have. I use that almost exclusively dealing with mine. I may only have to deal with mine maybe once a year, twice a year at most. But that and the exercises that I do helps me keep mine under control. And so let's talk about some back to normal issues and some first steps with that. As a physical therapist, whether it's a shoulder issue, whether it's a neck, whether it's a knee, whether it's a hip, regardless of what the issue is, what I'm looking to find out from myself or for anybody that I'm seeing is, can I reproduce the symptoms? We have lots of tests and lots of things that we look at as far as strength and motion, and then special tests to decide if we can reproduce this pain and target a specific functional problem or piece of anatomy with that. And so that's what we're looking for as things being reproducible. But let's talk about traditional physical therapy. So like I said, I graduated in 1994 and spent a good deal of time just treating shoulders like we were taught to in school. After school, I got some more advanced training and learned a little bit more about what's going on with the shoulder. But we focused on that shoulder itself. And in doing that, the numbers are about 25% of the people that we saw, we treated very successfully, didn't have to have any surgery, got them back to normal, and didn't have any issues at all. About 25% of them just really didn't respond and probably had to go on and have some sort of either surgery or some injections or get on some long-term medication. And then 50%, they felt better because they were doing the exercise and they were staying active, but they were still dealing with some significant pain and limitation in the shoulder. And so that's what traditional physical therapy looks like. If you've ever had therapy on your shoulder before, you probably fall into one of these categories. And I'll be honest, a lot of traditional physical therapy still operates this way. A shoulder comes in and they're just looking at the shoulder joint itself. So what I did with some of the training and advanced work that I've done is implemented all four of those systems that we talked about, including the neck, the collarbone, the first and second ribs, and then the shoulder blade. So once we started really applying that whole system as one, and as opposed to just dealing out here with the shoulder, our numbers really started to change and we started to make a real impact for our patients. So here we looked at, all of a sudden we could deal with that shoulder pain, and our success rate is up to 90%. I will be honest, there's still 10% of the people who are watching this, 10% of people out there who are dealing with shoulder issues that are probably still going to have some surgery. There's some tears that are just so significant that they can't be dealt with without that. But what we're going to talk about in a little bit is we can live with some small tearing. We can live with some of those things and still have good function, have good motion, and have no to very minimal pain. And that's the category that I fall in. Putting all four of those systems together makes a significant difference in the outcomes that we see. So I'm going to jump here. Well, we'll go with this. Again, we want to know if your pain is reproducible. If it is reproducible, then there's definitely hope, because if it's reducible, we should be able to reduce that shoulder pain. A pain that stays constant is a bigger problem. that usually means there's some underlying issue that's not treatable, other than maybe a surgical intervention. But my experience and our numbers that we look at, that's really about a 10%. I'm not afraid of a small tear. What I'm afraid of is a pain that's constant, and we can't, after we reproduce it, we can't make a change for it. So if it's reproducible, then the good news is that it is reducible. And so back to the worksheet, if your pain, numbness, or tingling is reproducible, then it is reducible. And so and we didn't talk about it a whole lot, we'll get to it in a second. A lot of times the nerves coming out of the neck will go down above the first rib, below the collarbone, and if there's a lot of tension, a lot of pain, and a lot of tightness there, then those nerves can actually get compressed out here, and then we can see that tingling or numbness out in the arm as well, even out into the hand, and maybe even see some weakness out there. So, but if we can reproduce that, then we can reduce it. So, we talked about this earlier. In the past 30 days, the worst pain that I've had was, and I want you to think about your own shoulder pain that you've dealt with. Myself, I've had a pretty good month with my shoulders. I haven't really had any issue. I've had a little popping and some weird sounds and so forth, but it wasn't painful. And so I'm going to say in the past 30 days, my worst pain, if I graded on a 0 to 10 scale, 10 is my worst imaginable, 0 is no pain. And maybe a 1, maybe a 2 at most. Mine tends to be, if it's going to be an issue, it's going to be in the morning, because I tend to sleep on my shoulder, which I shouldn't, but I sleep how I sleep. So that's probably the worst that I've dealt with. So think about what you were doing and what happened whenever you had your shoulder pain at its worst, and then how bad was it? And so, like I said, I have pain for me, it's whenever I'm sleeping. If my shoulder is irritated, sometimes it's when I'm reaching overhead. For some people, I see this in mail carriers. Whenever they're reaching back into the back to grab mail to put into a box, that tends to be a problem for them. For some people, it's getting milk from the refrigerator. For men, a lot of times it's reaching back to get into that back pocket. For the ladies, sometimes it's trying to reach back for putting on the bra or coming up to fix your hair. And then for some people, if they're trying to get up from the floor, that just puts a lot of strain on the shoulders itself. So, what were you doing when you had that pain? What was the activity? And the good news, if there is a cause, and then we can usually elicit a change. And if we can do that, then there's hope. So I'm going to talk really briefly about cause of a problem. This is any problem. I'm going to use an example of what to do with a problem. The very first thing with any problem, I don't care if it's a shoulder issue, whether it's a relationship issue. The analogy I'm going to use is with potholes in a road. So where I live, the city rarely comes down and takes care of the streets where I live, and so we have lots and lots of potholes down here, and so they ignore it. The potholes continue to get bigger. There's one that's on a really sharp incline, and at some point they're going to have to do something with that. Right now they're ignoring it, and so this is what we think about with shoulder pain. So that shoulder can hurt. There's times it can be a little bit better, but it consistently comes back. And what do we normally do? We're human beings. So normally what we'll do, we'll ignore it and hope that it'll go away and get better. And if it's a situation where it's gone on for 3 or 4 days, a week, something like that, and ignoring it may be fine and probably a good choice. Just give it a little time, see if it'll go away. But a lot of people that are on this workshop, this is probably something you've been dealing with up to 6 months to several years. And so you've probably been ignoring it for a long time. And so the second thing, if ignoring it doesn't make it go away, the second thing we can alter it. So when we talk about my pothole analogy, well, I mean, it would be nice if the city would come in and at least put a little asphalt in there, at least smooth it down for a little while. But that's just a short-term fix. That's not going to fix that thing, because we drive on that over that fresh asphalt for a little bit. It's going to wallow out again. It's going to be a problem. And when we talk about the shoulder, what we're talking about here is using prescription medications, or going and get injections, or even having surgery. And so the reason I discuss this is normally with a rotator cuff problem, there's a mechanical problem. We talked about those 4 pieces that we look at of function that we have to look at in order to get some improvement with the shoulder. Well, you can get the drugs or injections or even surgery, but I've seen time and time again, if you don't change the mechanical thing that's happening in either the neck, in that first rib, in the shoulder blade, in the collarbone, if you don't deal with those, then even after those things, you're still going to have that same mechanical physics problem that's creating the issue out there. Again, we can have tears, we can have bursitis, we can have tendonitis. Those things can be managed. What tends to be an issue is what is the issue that's creating that to happen in the first place, and that's where I come in. That's what I want to look at to see if we can change that, so then we can knock that pain down, and then you can get back to normal function and normal movement. So that's we can alter it, but ultimately we've got to handle it, and that's handling that mechanical factor that's making it happen in the first place. So here, mechanically, handling it for my road analogy, they've got to repave the whole road. If they don't change the mechanics of how that road functions, then we're going to continue to wall out that pothole, and it's going to continue to stay a problem regardless of how many times they fill that pothole in. And so with the shoulder, it's about getting natural treatment, learning to manage your symptoms and be able to identify when there's an issue and mechanically what's happening to make this thing happen. And so that's what you can do, and that's any problem. So things to do when faced with a problem, back to the worksheet. Number one, the number one single biggest mistake shoulder pain sufferers make, number one is they ignore it. And again, I ignored mine for a long time until I learned that I could take care of it. So that's, and this is whether it's a shoulder pain problem, a back problem, regardless, that's the number one biggest thing is we ignore it. And the 3 things that we can do about the rotator cuff shoulder pain right now is we can continue to ignore it, or if you're already taking pain medications, you're going in and getting the injections every 6 months, you can continue to alter it. Or lastly, we can handle it, and that's what I'm talking about. That's what we need to look at, see if we can change those mechanical issues that's causing that. And again, I'm going to keep pointing to the freeshoulderscreen.com to get that in there so that you can be one of the 10 people who I'll just bring in for free to look at mechanically what's going on. And so now let's talk about the 3 main causes of shoulder pain. There are lots and lots of reasons a shoulder can have some things going on, and I'm really condensing this down quite a bit. But by and large, this is where it comes from. So, but let's talk a little bit about what normal imaging looks like. In the medical profession, we tend to rely very heavily on an X-ray or an MRI. And we're going to talk about why sometimes that is a good idea and sometimes why it's not so good an idea. So whenever we look at this, we talked about the collarbone, the shoulder blade right out here is the acromion, and then the upper arm right out here. And so I'm not seeing any spurs. We've got some nice space in between the joint right here. So this one looks really nice. The problem is this could be the X-ray of somebody who is having severe debilitating pain. So imaging doesn't necessarily show us, we don't see pain on this picture. And that's what we're trying to figure out is what is the pain, what's happening. So to talk about a little bit about some numbers. There's MRI studies of adults who have no shoulder pain show that 20% have partial rotator cuff tears and 15% have full thickness tears. And these are people that have no shoulder pain whatsoever. In addition, in those people that are 60 years of age or older, fully half or 50% who have no shoulder pain or injury had rotator cuff tears on their MRI that they didn't even know about. So what that tells us is even though there may be something going on in there, we could still have normal function and normal use of the shoulder. So we have to be careful of how we interpret these imaging studies that we have. Another thing, a study on professional baseball pitchers showed that full 40% of them had either partial or full thickness rotator cuff tears, yet they had no pain while playing, and they also remained pain-free even 5+ years after the study. So as a clinician, whenever I'm looking at somebody, I love to see the imaging. I think it's fantastic to have. But I'm more interested in what are the mechanics of what's happening in that shoulder and how is it functioning? What's the motion like? Is there something in the neck or in the collarbone or in the shoulder blade? Is there something that's not moving and causing a mechanical issue? That means a lot more to me than what I might see on imaging. So the translation here is, do not panic if your imaging shows a rotator cuff tear. It is not necessarily associated with shoulder pain. And I've got a testimonial a little bit later that tells a little bit more about that. So again, on the imaging, we have to be cautious of the vomit and the barf. So what is vomit? Vomit is the victim of modern imaging technology, and the barf is the brainless application of radiological findings. And so what that really means is when we treat based solely on imaging findings alone without any clinical correlation, we have to know mechanically what's happening in there. Because as we age, we are going to have some wear and tear. We are going to have some small tears. We are going to have some things that happen. But what's happening to create that situation? So don't be a victim of the vomit or the barf. So now, 3 main causes of shoulder pain. Number 1 are neck problems. Here we're talking about stenosis or arthritis or the degenerative disc disease that a lot of us tend to have. With stenosis, we start losing some disc height. It compresses on the nerves coming out of the neck out to the side. We'll take a little look at the picture here. On the left side of your screen, I've got a little diagram, and this is looking directly forward onto a person. So that the X-ray right next to it in the middle left, the person is looking directly at us. And so we look at the disc with stenosis or arthritis. This disc starts to compress down. It loses some height. And when that happens, we tend to also see, especially with age, these little gray things. Just consider those to be bone spurs or lipping around the vertebra of the spine itself. And so that would be right here where that lipping would take place. Well, whenever this compresses, it lowers down the amount of space that this nerve has to come out. And whenever that does happen, then it can affect everything that's happening further out in the shoulder. So neck function is very important. And in the 2 pictures on the right, again, we're just looking at it from the side. The issue here is we can also, with this compression coming down or this loss of disc height, we can also see compression on the spinal cord itself. And so there's got to be something that can be done to deal with that. And we'll talk about that in just a little bit. So the other issue is the rib cage in the first rib. So we just talked about how we can have stenosis in the spine over here, and then it create an issue where the nerves get impinged as they're coming out. Well, another thing that can happen is this first rib. So if you, and I do this, if you sleep on your arm like this, whenever you wake up, that first rib could actually come up like a bucket handle. And the problem with that is you see the nerves that come out of the neck, they make up what we call the brachial plexus. That gives us all the nerve supply out into the upper arm all the way down to the fingertips. Well, if that first rib comes up and gets stuck a little bit high, then it causes extra pressure between that bone and the rib and the collarbone here. And that creates a lot of extra pressure there. So function of that first rib is incredibly important. And another thing that we look at is just limited range of motion. So the shoulder has 3 basic planes of movement. The neck has 3 planes of movement when we're dealing with that. We've got up and down, reflection and extension. We've got rotation, which is looking left and right. And then we've got the side bending, ear to ear. And whenever I'm looking at a person, that's one of the first things that I look at is what is the neck doing? Is a person, they got some shoulder pain on this side, and are they kind of have a little crick in their neck, or they have a difficulty rotating over there? Well, we have to deal with that in order to get that shoulder to move normally again. So the second cause, and this is probably the more common thing that we typically look at, is what we call impingement. Now, impingement is just kind of exactly what it's talking about. We're losing space in where all these structures need to be. So with that, we're talking about the supraspinatus muscle, this upper rotator cuff muscle. Again, it sits on the shoulder blade, and it goes underneath the acromion right here. And what these little things are out here, that's our bursa. And so what their job is, just provide a little cushion. Well, as you can tell, we have a very limited amount of space in between the upper arm bone, or the ball, and this place right here. So if this muscle gets irritated and it starts to swell, it gets inflamed, and then we have these bursts in here as well, then we've lost a lot of space. And what tends to happen is, instead of lifting our arm up in a normal motion, we tend to bring it up, and then it jams in that area right there. With all that jamming, we can get some little tears in the rotator cuff. We can get some bone spurs start to develop. We can get a lot of issues that take place. So impingement has to do with that space there in that vicinity. Here we tend to have trouble reaching behind our back. This is side sleeping on a raised arm. Again, the space gets very small. We get some bone spurs. We can get some fraying of the tendon out here, and that can lead to a small tear. And so I've got just a little video here that shows a little bit about this, and some three-dimensional with some motion. And so I'm going to let this come forward, and you can see that space between the acromion and where that muscle sits. Normally it moves nice and smoothly, but we're going to spin this around in just a minute. Let me see if I can move that forward a little bit. Okay, here you got a view from the front where you can see there's not a whole lot of space in there. So if those tissues are already inflamed, that impingement is going to be a big issue, and it becomes very easy for that muscle to get caught, and then it changes the dynamics, the mechanics of how this thing moves. So the impingement causes a lot of other issues that we have to deal with. And then finally, the third cause of shoulder pain, it sounds very basic, but I preach this to everybody that comes in, is poor posture. And we'll do a little demo here in just a second, but let's talk about, whenever we're thinking about posture, especially up here, we're talking about this leaning forward. You know, we're looking down at our cell phones, we're playing on our computers. Most everything we do is down in front of us. So when we do that, our neck seems to flatten out and our head comes forward. Well, whenever we look at this from a physics standpoint, whenever this head moves forward in front of our center of gravity, the amount of weight that is produced in that lower neck becomes more significant. So in normal posture, the force there is about 10 to 12 pounds. The further forward we get, the force itself can increase all the way up to about 60 pounds. And that is a lot of force. And where that force is transmitted is between the 6th and 7th and cervical vertebra, and the 7th and 1st in the thoracic. And all of that is what gives us all of this business right out here. So one of the first things that I'll do is tell a person, hey, you got to start working on your posture. And so as a demonstration of how neck posture can impact the function of the shoulders, I want you to just sit, and I'm going to turn sideways so that you can see what I'm doing. So whenever we're sitting with nice erect posture, chin is tucked and we're sitting nicely, now we bring the shoulders up, and I'll bring both of them at the same time. Okay, we get good motion when we have good posture. Okay, so now if I slouch down and I drop my head like I'm trying to read something down here, now all of a sudden I try to bring those arms up, and what happens? If you haven't, try that for yourself. You bring those up, and all of a sudden I've lost a significant amount of motion. And so just the difference in posture can greatly impact what's happening in the shoulder. And so posture, as well as those four pieces, become very important for proper function of the shoulder. So back to the worksheet, the top 3 common causes of shoulder pain. The first one, it's a neck problem. There's something going on here. There's a limitation in rotation, or looking up or down, or bending side to side. So the neck problem is number 1. Number 2, it's impingement. There's something that's happening out in the rotator cuff itself between the acromion and the muscle itself as it comes down. So impingement is B. And then C is posture. And if you didn't, I really encourage you, do that slouching thing. See how big of an impact that makes. So if there's anything that you take away from this, if you decide not to let me look at your shoulder to see what's going on, look at your posture and see what's happening there, and see if that will make a change in what's happening for you. So what does successful natural treatment look like? Well, right now we're doing these workshops via the computer, via your phone, and that's fine. Normally I like to have a person come in and I can, take 5 minutes and evaluate what's happening and show you hands-on what this looks like. Through the computer, I really can't do that, so let me just try to describe it as best I can. Number one, you have to have some hands-on PT to move that shoulder and the surrounding joints. If we don't put our hands on it and make some corrections to the mechanical issues that are going on, either in the neck, collarbone, first rib, shoulder blade, we have to make a mechanical change in that. And that can be from simple mobilizing the joints, and in some cases it can be a little bit more aggressive adjustment or manipulation, if you will. So you have to have some hands-on treatment. The second piece, you have to work on some stretching, and most specifically the strengthening exercise to retrain muscle memory. So we look at the 3 phases of healing, and those phases are, number one, we have to knock down pain. That is always the important part. We want get that pain gone. But if we don't do the next pieces, then all we're doing is we're altering it. We're not handling it. So the stretching and strengthening become critical to restore motion, restore strength, which lets us get to the 3rd phase of healing, which is getting back to our normal activities. So being here, stretching and strengthening is critical to getting that next step going. And then the last part, or number C here, dry needling or a class 4 laser to break the pain cycle. 20 plus years ago, we would use just heat or ice, or we used ultrasound a lot. And those things are fine. There's nothing wrong with them. But what we really want to do is see within the next treatment or 2, at most, can we knock that pain down considerably? If your pain, a person comes in, their pain is at a 6. Well, I want that pain knocked down to a 1 to 2 extremely rapidly, so that we can then get on to what treatment actually is about, which is the strength, the flexibility, and the stabilization and getting back to normal. And so the dry needling or the class 4 laser, which the class 4 laser is basically, it's the same thing that the veterinarians have been using on horses for years. And so we've recently been afforded by the Food and Drug Administration to use these for human treatment as well, and we find really good success with that. I personally feel like we get a lot faster response out of dry needling, because we can directly interact with the muscles, the tissues that are the problem in the first place. And so that's a key part, is getting that pain knocked down. Once that's done, then we move on to the rest of the treatment. And so I have a few testimonials of some folks that came in. This is Donna. She came in. She had a significant issue going on with her shoulder, had a hard time lifting it up overhead. You can see Kat here. Kat here is one of my physical therapists. But she had remarkable success. She did have some tearing. She did have some issues in there, but we restored her mechanics and got her strength back, and she's able to get back to where she needed to be. This is one of the best ones that we've got. Nancy came in. When I first looked at Nancy's imaging, she had significant tearing, almost complete rupture of one of her rotator cuff muscles. The other one, the main one, was completely ruptured. And I was honest with her that I didn't know how much we would be able to get back. However, in her case, her pain dropped significantly, fairly quickly, and we were able to get that strength and that flexibility and that motion back, so that she could go from where she couldn't even move her arm at all to where now she can raise it up and do anything that she wants to, and the shoulder is not an issue. And then Martha, similar. We applied those 4 pieces of treating the shoulder with her, made a significant difference in how her shoulder responded. Again, she feels better than she has in several years. And again, advanced treatment approaches, even though there's some tearing, even though there is some pathology in there, we changed the mechanics and she got back to normal. And so one of my favorite ones, now this, Elaine here, she wasn't a shoulder, she had a chronic knee pain. But we applied these same approaches to her. She really probably was one of those 10% folks that really needed to have surgery. Because she's taking care of her son, Jeremy here, she can't be out for surgery to do that. And so we applied those techniques. She's 75% better than where she was. And I'll consider that to be fantastic, considering that she really needs to have surgery. But she's done remarkably well, and very special situation. So here's what we need to do next. Again, if you have some questions, feel free to jump in, throw them in there. Again, what I really want to do, I've got spots. I'm going to give for 10 people a free screen. There's no commitment. I don't need money. I don't need anything like that. We'll take a little time and look at what your shoulder is doing, see if we can find out. Maybe it's something as simple as changing your posture. But I want you to go to freeshoulderscreen.com. Our numbers are on there. You can call or text either of those. But let's get in there and get your information so that we can take a look at what's going on. Some people want to be seen right now, and we can do that. We can do that either in the clinic or we can do it through telehealth. Either one that we want to do. You may not be comfortable getting out of the house, and that's perfectly fine. If we get your information, we can go ahead and schedule something for a week from now, 2 weeks, a month, whatever you want to do. But we can do it either in the clinic or we can do it online. So when you click that freeshoulderscreen.com, it's going to bring you to this page, and all you really have to do is enter your name, your email, and then give us a little message. Say, hey, I want to look at my shoulder and see what's going on. Just something that knows that we need to reach out to you to get some information. So my offer again, and I don't do this to everybody that walks in the door, but you've taken your time to listen to me ramble on about the shoulder and so forth. So here I'm gonna give, again, first 10 people who go to freeshoulderscreen.com or let us know in the chat box down there. We'll do the free consult, and what we'll do, we're going to look at certain movements. I'm going to feel your shoulder to determine what might be causing your rotator cuff and your shoulder pain. We want to find out if there's something that can be done to heal it naturally. I'll give you some tips, what I think is going on and what you can do. At the end, if you decide you want my help, then I think that's fantastic. If you decide not to try to do that, I'm not going to try to sell you on it. I'm just trying to give you a little information on what might be happening and what you can do for it. Again, and that's the whole goal, give you the information on what's going on and what you can do to handle it. We've already been through ignoring it or altering it. It's time to handle these things. And so let's talk really quick, the difference between a free consultation and an evaluation. Also, it comes down to the time. With a free consult, I'm going to bring you in. We're just going to take maybe 15 or 20 minutes. We're going to look at the movement. We're going to look at the things, and we're going to see if we can determine what a potential cause is and then what successful treatment would look like. Then you get to decide, that's good information. I don't really care to move on, and that's fine. A full physical therapy evaluation, we're going to take 45 minutes to an hour, and we're going to identify what's happening there. And then we're going to go ahead and we're going to apply successful treatment. We're going to put hands on. Maybe we need to do some dry needling. Maybe we need to deal with the neck. We're going to go ahead and apply that. And then we're going to sit down and we're going to plan out a care plan to get you taken care of. This is usually the point where I will tell people we have a lot of folks that do come in and they just want a quick fix on their pain. And I don't mind trying that. If the longer a person's dealt with a problem, the longer the mechanical piece has changed, the longer we've had some change in how the body is moving. And we can knock pain down, but if we don't deal with the mechanics, then we're not going to really take care of this long term. And that's my goal. I don't want to keep seeing a person month after month, year after year for a shoulder pain just to knock the pain down. We can identify the cause of what's happening, and address that, and then you can move on and not have to deal with that. And so that's the difference between just a free consultation and a PT evaluation. Right now, I'm just trying to see if anybody wants to have me at freeshoulderscreen.com just to come in, take a look, and I'll give you my 10 cents on what I think is going on and what we can do for it. So again, 10 slots there. I'm going to step aside here just a second and see if there are any questions that I need to answer. There's our contact information. Easiest way to get to us, though, is right here, going to freeshoulderscreen.com. So I will jump to Ashton and see if there are any questions that I didn't cover. I apologize if I rambled too long, but
okay, I'm back here. I apologize to everyone if it's loud. They are tearing up the sidewalk outside of my office and being quite loud about it. We did have one question from Lindsay. She wanted to know how long the average length of treatment, like how long someone normally has to come in for therapy for this?
Well, that's a great question, and I'm going to say in large part it depends on how long you've been putting up with the problem. A person that they were a weekend warrior. They went out and they did something. They lifted something too hard, or they exerted too much, and they've got a little strain up there. That sort of thing usually might just be 2 or 3 treatments. Quite honestly, a person that's been dealing with a mechanical problem and pain in the shoulder for 6 months to a year to multiple years, or in my case, decades, it's going to take a little bit longer. Usually what our goal is to take usually 12 visits over a 1-month period. And at that point, we should be able to wean the in-office stuff down and get you doing the exercise and the piece that you need to do. Again, first step is let's knock pain down, but more importantly, after we knock pain down, let's give you the tools that you can do on the motion and the strengthening to keep this thing under control.
That was all the questions we had.
All right, fantastic. So I'm going to leave this up for a little while, this screen, so in case you need our number, if you want to hit some more questions down in the bottom, if you want to take advantage of having me look at your shoulder and see what's going on, again, go to freeshoulderscreen.com and we can do what we need to do and see if we can't take care of you. Thanks for coming out.